Good afternoon, everyone. Assalamu alaikum. You don't need to be in tech to care about AI. Because if we look at healthcare alone, AI is enhancing accuracy. It's reducing costs. It's paving the way for new treatment options and many other benefits. But as well as the unprecedented opportunities and progress that AI brings, it raises ethical considerations at the forefront of research and policy. And earning and maintaining public trust is essential for the adoption of AI too. Misuse or high-profile failures could lead to widespread distrust in both AI and healthcare systems. My name is Louisa Baldini. I'm a former BBC correspondent, and I'm delighted to be with you this afternoon leading this discussion on the ethical management of AI in healthcare as considered through the lens of Islamic bioethics. I'm very pleased to introduce our panel, so when I call out your name, please do make your way up to the stage and take your seat. Firstly, joining us is Professor Mohammed Ghali. He is Professor of Islam and Bioethics and Head of the Research Center for Islamic Legalization and Ethics at the College of Islamic Studies at Hamad bin Khalifa University here in Qatar. Welcome, Professor. We also have Dr. Hans Kluge, who is the World Health Organization's Regional Director from Europe. Welcome, Hans. We have Dr. Tamar Schiff, who is postdoctoral fellow from the Division of Medical Ethics at the Department of Population Health, New York University Grossman School of Medicine. Welcome. We also have Dr. Barry Suleiman, who is the Assistant Professor of Law from Hamad bin Khalifa University. Welcome, Barry. And last but not least, from the UK, we have Andrew Gwynn, who is Parliamentary Under-Secretary of State for Public Health and Prevention. Welcome, everyone. So before we get started, just to say that there is a translation available. If you haven't grabbed your headset from just outside, maybe now is the time to do that. We'd really love you to be able to follow this discussion, which is going to be in English. And there will be an opportunity for you, our audience, to pose questions to our panel a little later on. If you could please use the app to submit your questions, make them to the point. If you can, please, can you name the person you would like your question directed to as well? And I will put those questions to the panel after this initial discussion that we're going to have now. So we are using as the springboard for this discussion the report published by WISH, authored by Professor Ghali and Dr. Suleiman, as well as some others of your colleagues, entitled AI and Healthcare Ethics, Islamic Perspectives on Medical Accountability. And so to you first, Professor Ghali, I guess the first question is for you, or from your research, what have you found are the most pressing ethical concerns regarding the use of AI in healthcare that are distinct or specific to Islamic bioethics?
Thank you so much. First of all, due thanks to the colleagues who contributed to the report, the co-authors, the various co-authors, and those who are also from behind the screen, from WISH and from outside, especially to Maha El-Akoum, who worked under difficult work conditions. Sincere and due thanks to her and to the team. For your question, what we have been doing while preparing for this report and working on this research, one of the main and the core elements of medical ethics from pre-modern history till now is the physician-patient relationship. We have a powerful stakeholder, that's the physician, And the vulnerable stakeholder, that's the patient. Usually we add more responsibility on the powerful stakeholder and more protection for the vulnerable in order to make this encounter, this power imbalance to manage it in an ethical way. Keeping in mind that almost all the time, the physician has full control on the tools that he or she is using. So if I'm using a surgery knife, the surgery knife will not cut without me using it. So it will not do things by itself, and many other things. Now, with the AI, we will have a tool, I would say for the first time in history, that we call it SMART tool. It has a level of autonomy, decisional capacity, can make recommendations. We have an X-ray, I can say this is cancer, this is not cancer. I, as a physician, may not know why this decision happened and how it came because of the black box problem. So we have a new stakeholder in between that can have more power even than the physician himself or herself. How to manage this? This is an issue, a big issue for everyone, Muslims and non-Muslims. From an Islamic perspective, this has to do with what we call authority over our bodies. In Islam, the belief is that God is the creator of the body and thus the ultimate owner and the one who has the ultimate authority over it. So if God decided taking out your life, now we may call euthanasia, active euthanasia is prohibited because you didn't start your life, you cannot terminate it. The consent of the patient, the acceptance of the physician does not make the act unethical. Why? Because the permission of the lawgiver with an uppercase L is not there. So how much authority do we have as humans, whether patients or physicians, over our bodies that now should be interpreted when we have this new tool, when we have medical accountability, how this medical accountability should work? This is what we have been studying in the report.
So the way you've described it sounds quite set. Is there any room for interpretation? Is there flexibility in Islamic bioethics to take into account new procedures, developments in healthcare then?
Yes, for sure. This is a discussion which is still in the beginning. This report may be one of the very first contributions to the discussion. But what we have seen throughout the history of contemporary bioethics, Islamic bioethics, is strongly characterized by diversity. There is hardly any topic in which we do not have different opinions. Of course, it doesn't end up into chaos, that anyone can do whatever, anything, and we end up in ethical relativism, everything is possible or not possible. There are majority positions, minority positions, accepted disagreements, unrecognized disagreement, and so on. So I can expect that this one also would have that. You have a number of set principles that I have outlined, and then you will have discussions. We highlighted some of them even, this openness for possible disagreements in the future, when there is, for instance, a situation, the AI is an emerging technology, safety and efficacy is not well established, so we speak about risk higher than normal, higher than usual. What if the patient said, I'm fine, even if there is no standard of care, etc., even there is a risk for my body, but I am the one who can decide about my body, how far can we go, etc. We will have, for sure, diversity of opinions about these things.
Now, before I open the discussion wider, I just want to come back to you one more time, because obviously you co-authored the report. So what did you find are the solutions, especially from the Islamic bioethics point of view? What are the key themes and recommendations, if you can, in a nutshell, very briefly?
In a nutshell, very briefly. Two main things. And you spoke about what's specific to Islamic and to the rest. I would say they are very rooted in the Islamic tradition, and I can give detailed reasoning later. But they are also in agreement with the emerging perspectives that we have even outside, so global even perspective. Number one, having this machine, it doesn't matter how smart it is, how autonomous it looks like, it cannot be responsible for any mistakes. So we cannot say to the people coming to the hospital, something goes wrong because of using AI, and we say to the people, you know what, we will suspend this machine for 2 months as a punishment. And then I would say as a patient, oh, that's great, that the machine will be punished. There is no such a thing, it doesn't make sense. In Islam, the only beings accountable in front of God are humans. Not machines, not plants, not animals. So it must be a human. This is number one. Number two, it cannot be the physician alone anymore. So in the past, the physician was always the first one to be responsible and to be held accountable because he had control over everything. Now we have a machine that does not have control. So we cannot make the machine responsible. What should we do? We bring those who made the machine. So there are data scientists who choose the data. Maybe there is a data bias, and they should have looked into this. The developers, the programmers, a computer scientist, people who were part of this new thing that came in between the physician and the patient. So we are moving into a more collective liability than the traditional, conventional, individual liability where the patient was, where the physician was normally speaking the first and most of the time the only liable person.
Thank you very much. Dr. Tamar Schiff, I wanted to ask you then, we've heard some of those ethical considerations specific to Islamic bioethics. What do you, from your perspective at NYU Grossman School of Medicine, what do you think are the long-term ethical considerations we should keep in mind as AI technologies continue to evolve in healthcare?
So again, thank you for including me on this panel. Professor Ghali in the report obviously gave a great review of a lot of the ethical issues, so I'll try to touch on the kind of a few buckets of especially prominent concerns without being too repetitive. So, of course, a very important one to us all is autonomy and informed consent. But I want to raise, what does that really mean in the context of AI? First of all, as was mentioned, there are these inherent limitations around the explainability, the black box of the technology. And that really raises this new kind of, in shared decision-making, now both parties, the physician and the patient, have limited understanding of the technology being used. And the second important...
Sorry, could I just interrupt briefly, just because you've both mentioned this black box idea. Can you just explain that before we proceed, please? Thanks.
So in brief, the idea is that this technology is developed and trained on an initial data set or multiple data sets, and it learns iteratively from itself. And then at some point, the algorithm is complicated beyond what the developers developed, and what the model is now doing is beyond our exact explainability or comprehension. So it's essentially functioning in this black box, and we do, you know, in many respects, trust the results, even though we can't explain the step-to-step.
So it's almost like it grows a mind of its own, and is that the fear, one of the fears?
Yeah, I mean, I think that's, and I'm happy to let you jump in, Professor Ghali, but I think one that is really where the term artificial intelligence comes from is the idea that it learns on its own, not in any sort of nefarious overtake the humans way, but yes, beyond what it was initially programmed to do.
Okay, thank you. And if you could, we might come back to that, but if you'd like to, I interrupted you, so I'd love you to finish the points you were making. Thank you.
So just one more quick thing on autonomy is just that there still needs to be this balance of transparency. I think sometimes we have this impulse to say, well, let's just give the patient all the information, but I think that can be a hindrance to informed consent. There still is the obligation on the informed party, the physician, to recommend, to give guidance. So I think that's an important balance here. The second kind of bucket of concerns I'll bring up is equity and justice, and specifically I'm thinking about access in two parts: access to participating in the research and being part of the data sets on which the AI is trained. So questions of representativeness of this data set, and in turn what biases are baked into it, and then of course data privacy and ownership and protections around that. And then that second part of access is access to the downstream applications once the model is developed. And so that raises issues around affordability, sustainability, and then I think there it's especially important to be sensitive to the impacts of historical abuses of certain populations and therefore their hesitations to partake in these new technologies. That's something that needs to be thought of in rolling these technologies out. I'll blitz through a couple more points here. So just the last thing I'll mention is oversight and accountability, and there I think we need standards and standardization. What I mean by that is developing regulations, so that's the standards, but then also harmonizing those regulations across a different region, so that's the standardization, and that really will require a lot of supportive and collaborative infrastructure. And two super quick comments just about the larger discussion of ethics in AI that I think is just important beyond the specific considerations. One is that we really need to define what AI we're talking about, as is mentioned in the report, and I think a lot of people are aware. AI is capable of doing so many things, from drug development to diagnostic aids to help with documentation. Each of these carries its own implications, its own ethical considerations, so we really should be specific about which ones we are talking about. And the second thing I think is important to mention is that we should just be self-critical in this discourse about avoiding this exceptionalism around AI where it doesn't belong. So there's a lot of things that are really special to AI, but there are some that are not. And we do have kind of already thought out ethical approaches to applications of emerging technologies, ranges in clinician proficiencies. And so where we do have these approaches set and they apply to AI, we shouldn't be hesitant to use them just because AI is this shiny new thing.
Yeah, very good points. Thank you very much, Dr. Schiff. And you mentioned equity and justice. So, and you also mentioned regulations. We'll come to regulatory challenges, but to that point on equity and justice, just your view before we go to Dr. Kluge from the World Health Organization. In your view, can AI in healthcare be managed to avoid can it be managed to avoid exacerbating existing inequalities in access to care within the MENA region? And what steps can be taken to ensure that all communities benefit from AI advancements?
So again, it would be nice for there to be a simple answer to that. I think there are a few kind of approaches we can discuss. And we were joking before the panel that as the bioethicist, it's really convenient to say, like, we need to discuss. We don't give an answer. So I think the first is to really employ proactive or anticipatory bioethics, really trying to anticipate the problems that will arise rather than playing catch up after the fact. And the bookend to that is once AI application is implemented, the process doesn't stop there, needs iterative assessment and improvement. And to do both those bookends well, we really need to include diverse stakeholders at every level, from the conceptualization, the needs assessment, the development, the data set training, all the way to implementation, and then that iterative assessment. That's the way to make the AI benefit everyone, is to include stakeholders from diverse regions, from diverse populations at every level. And to be very deliberate about which AI applications are put into place. And then kind of circling back to the point I made a minute or two ago, just being very conscious that it is very important to address AI-related concerns, their ethical, legal, and social implications, but not to lose sight of other sources of inequity and address those as well. Again, we might get stuck on the kind of shiny new thing and the issues it raises, but they don't exist in a vacuum, and other sources of inequity still need their fair share of attention.
Thank you very much, Dr. Schiff. And Dr. Hans Kluge from the World Health Organization. What work are you doing at the WHO to establish global ethical standards for the use of AI in healthcare? And you are overseeing the EU region, so maybe you can talk to us a little bit about specifically the EU, please.
Thank you. First and foremost, I would like to thank the Qatar Foundation and the Minister of Health of Qatar and my sister, Dr. Hanan Balkhi, the Region Director of the Eastern Mediterranean region, for inviting me here. It's very exciting to be in this panel and the audience to learn from each other. Maybe a clarification up front. So I'm the Region Director of the European region, which covers more than the EU. It's actually 53 countries. So it goes from Greenland up to Vladivostok, Central Asia. So it includes EU, but it's much more broader. And I would say that if we speak about equity, everything we do should have equity at its heart as a starting point. Number one, because the guiding principle is the Sustainable Development Goals, leaving no one behind, which is more important today in this polarized world than ever. And second, economically, we know that inequities cost much more money if we leave people behind. Now, at the global level, there are several initiatives. I'm sure that many of you know that the United Nations Secretary General launched in New York at the General Assembly recently the report on governing AI for humanity. And one of the big outcomes, obviously, that there's a global governance deficit. Then WHO itself globally, under the guidance of Dr. Tedros, is having close collaboration with the International Telecommunication Union, WIPO, on ethics. But going back to the WHO European region, we see this broader. So we got the 53 member states approved our new health system framework on sustainable and resilient health systems. And it's built around trust and transformation. You mentioned actually the trust. And that's how we see it. There is a deficit of trust by the people in their health systems because there are waiting times, they don't get what they want. By the politicians that sometimes Minister of Finance feel the money is disappearing in the black hole. And then by the healthcare workers themselves who are burnt out. So we really need to restore that trust to transform our systems. That's the framework. Under that, we are developing a pan-European strategy on developing the ecosystem to accelerate public health innovations and AI, because it goes so fast that none of us can really keep up individually. And what we did is to create a public-private partnership between the innovation hubs, the science parks, the R&D centers in the European region, which are plenty with abundant resources, with huge networks, but they have no clue, actually, what are the pain points in the public sector from public health point of view. But they are willing. So that's WHO convening power to bring them together, this huge resource, with the 53 member states to align policies around the shared goal of equitable health outcomes. It's basically encouraging markets and economies to look beyond GDP as our sole marker. It's looking to put health and well-being in the center. To put it simple, if you are a mother alone with children and your child has a disease and you know that the government is going to take care of the expensive medicines, you create and foster trust into local governments. And whether it's of health systems or AI, that has to be the principle.
And that is the answer then, you think, when it comes to marginalized and undeserved, if we like to call them that, communities that may be forgotten, because obviously there is almost a concentration, we could say, of AI in affluent societies, maybe in cities. But what about all those other communities? So that's what you're saying, is to create this ecosystem is the solution to make AI equitable for all?
Yes, absolutely. We did a survey in the 53 countries in our region, and it's crystal clear. Ethnic minorities, people living in the rural areas. We have, unfortunately, millions of people from Ukraine, refugees, right, facing language and economic problems, but more and more also in the elderly population. We have a very big problem with demography. The fertility is plunging, and we have a rapidly aging population. And we know that digital illiteracy is particularly a challenge in those groups. So a number of points here. One is what we call co-create. We have to co-create it with the marginalized communities, with the elderly population, so that they can make informed choices which AI tools are acceptable to them. And then we have to educate the public. And we do have good examples. France, for example, has about 4,000 digital advisors working through local authorities to help educate the population. Luxembourg, the Ministry of Digitalization, every 6 months is calling different ministers together with digital inclusion advocates to solely focus on the people left out, digitally isolated communities. So not just, I don't want only to tell the challenges, but there are some good examples in high-income countries, because it's not, we should get away from classifying the world into low-income, middle-income, high-income. The problem we face in Europe, basically, are vulnerable people in high-income cities, for example. So you cannot look at the GDP of a country, you have to look really very focused and stratify. And I think, and finally, of course, the training of the healthcare workers. I think Professor mentioned it already, there has to be a balance between the power of the AI tool and the own clinical judgment. Recently, we had a workshop between experts of Latvia and Denmark looking at AI for screening of breast cancer mammography. And actually, in that case, it led to a lot of overtreatment, which was devastating for the women. Because as a woman, you're not diagnosed. You have, right, by the AI tool, a chance from breast cancer. And then second, third opinion say, no, it was overdiagnosis. You may be mentally, really impacted and do medical shopping until you find somewhere a doctor who says, yes, maybe there's. So it's a very delicate balance.
Some great examples there for us. Thank you very much. Before I come to you, Andrew Gwynn, from the UK, to you, Dr. Barry Suleiman, and Dr. Schiff mentioned regulation. So from your point of view and the research you've done, what are the current regulatory challenges surrounding AI in healthcare, and what improvements do you think are needed? Because regulation, one would assume, is key to keeping patients safe and allowing AI at the same time to evolve.
So, can you hear me?
Would you like to tap it and we can hear if it's there? Could you flick the switch?
There we go.
There we
you
go.
Can hear me now. Thank you for the question. So, just for some background, here at HBKU, we, as part of a team of co-authors and co-editors, we published the Research Handbook on Health, AI, and the Law, which was published a couple of months ago. Professor Ghali contributed to that, and I co-edited that with a professor from Harvard Law School called Glenn Cohen. And so this is now the field's main resource, which is free for people to read. And what we identified in the book were some 6 key legal issues that have to be tackled when it comes to AI in healthcare. So 3 of those issues pertain to data. We hear data discussed a lot, but what does that actually mean? It means, on the one hand, dealing with discrimination in the data. On the other hand, it deals with data privacy, and finally, it also deals with data security, which are 3 distinct legal issues. Another one is to do with medical liability, which is a big part of this report in what Professor Ghali has discussed from the Islamic Bioethics perspective. Another one is informed consent, which has been alluded to by Tamara, and then finally, intellectual property. So these are the key legal issues we've identified that systems need to tackle when it comes to the use of AI in healthcare. But actually, when we take a step back, we realize that systems are not really dealing with these issues very well. The response so far has been, in the main, that we've seen medical device regulations, which exist in some countries, but not in all of them, being sort of upscaled. So those medical device regulations have been amended to, or they've been appended with extra guidelines for those wanting to bring AI-based medical devices to a market. So that's great if you're a developer and you want to bring a product to market, but it doesn't deal with the legal issues that we identified, which is quite the gap. So what we really need from a regulatory perspective is to think about AI at the different stages of the process. So going from the very beginning, which is the research and development of AI requires some overarching regulations and guidelines. And another project that I've been working with here at Professor Ghali last 3 years has been to develop those guidelines, which are along with the Ministry of Health here. And those guidelines are now almost finalized. So that's the first stage. The next stage is those medical devices that I discussed and approvals for those, and that's its own area. And then finally, once we're using AI in clinical practice, what are the legal rubrics that are there to protect those who are using AI? And for me, I know we've heard equity being mentioned. To me, from the lawyer's eyes, the person I care about most in my research is the patient. That is my primary aim in all of my research. I think about that person who is either having AI being used in their care or they're interfacing with AI. And what are we doing as a system to ensure that what comes down at the end of the pipeline is for their benefit? So, as I say, I think that right now legal systems around the world aren't really tackling these issues in with sufficient rigor. one thing I'd also say is there are just clearly regulatory gaps, even in the medical device space. If you're a startup trying to bring a product to market in a country that doesn't have an FDA, you are already falling behind other companies who have the resources to get approvals in other countries, and you can bring your device to a market that doesn't have these approval processes based off your approvals in another country, and then the local market for developers gets left behind. So there's a lot to be said on this front, but we do need to think about this whole system approach, I think, to regulating this space, and it's quite a complex thing to do it holistically at least.
Thank you very much for some good points there on regulation. And so let's zoom in to the UK, and Andrew Gwynn here, Parliamentary Under Secretary of State for Public Health and Prevention, representing the UK. Thank you so much. So regulatory gaps, as we've just heard, can be the case, or is regulation watertight in the UK? What specific policies is the UK government considering to ensure the ethical use of AI in healthcare? And how do those policies aim to address concerns about accountability, transparency, patient safety? Big questions, not too long, but in a few minutes, please, if you could answer.
There's a lot to answer there, isn't there, in a short time? I mean, firstly, thank you for inviting me as one of the new ministers in the Labour government that was elected earlier this year. I think this is a truly exciting prospect for healthcare if we get it right. And that's not just at national levels, but also internationally. We have to have a degree of cooperation across the world to get the regulatory framework right, but also to tackle the inequality issue, because the benefit of AI is to tackle some of those endemic health inequalities, both within our respective nations, but just as importantly, across the globe. And the danger, if we don't get a regulatory framework right at a global level, is that you exacerbate health inequalities between the North and the South, rather than narrow those health inequalities. And that's why getting the regulatory framework is so important. Now, in the United Kingdom, we have a unique set of circumstances in that the vast amount of data that the National Health Service holds on patients across the United Kingdom can be put to much better use than it is, and this is something that the new government recognises. One of our commitments is to shift our NHS from analogue to digital. Now, that's a nice little soundbite, but sitting behind that is ensuring that we maximise the life science potential of the United Kingdom, we maximise the data potential of the National Health Service, and we utilise some of the latest advancements in technology. And AI has a huge role to play, and is already having a role to play in how we take the National Health Service forward. So, for example, in the NHS, we've got clinical decision support, so AI can be used to triage, can be used to diagnose, and can be used to help clinicians get the maximum health outcomes. It also helps with efficiencies within the NHS, right the way down to managing bed capacity in hospitals.
Does efficiencies mean that there will be job losses? And this is one of the fears, obviously, when it comes to AI. And has that been considered specifically in the NHS, the National Health Service workforce? Will there be job losses, or all jobs altered because of AI?
Well, jobs may well be altered because of AI, and as part of our 10-year plan, taking the NHS forward, we heard from Lord Darcy in the opening ceremony about the challenges facing the NHS in England and how he has set out the diagnosis, and we now have the prescription with the 10-year plan that we're consulting on. There is an opportunity there with the workforce to tailor it for the new needs of healthcare in the 21st century. We're very much still operating on a healthcare model that was designed for the 20th century, and it's how we use those shifts from hospital to community, from analogue to digital, and from sickness to prevention. And AI has a massive role there, but the ethical side of AI is that we have to have good enough regulation that ensures we strike that balance between improving health outcomes, but without ensuring that some of the risks and dangers that AI could pose don't occur. And that is what there's some really interesting work being done in the United Kingdom through things like the AI airlock and the AI Digital Regulation Service that hopefully will be a blueprint for others to follow.
And just very briefly, training must be such an important part of this when it comes to AI. It is, it has been around for a few years now. We are still talking about it as though it is brand new, and that's because it is so rapidly evolving and changing. But the Institute for Ethics in AI at the University of Oxford, said that they were aware some staff in the NHS were using ChatGPT to search for advice. And some patients have deregistered from their family doctors, their GPs, over fears of how AI may be used and issues of data privacy. So these are very concerning, aren't they? So quick response from you and then Dr. Barry.
They are, and that's why we've got to have a robust framework in place, and particularly when it comes to patient data, we've got to ensure that there are maximum protections there for the patients, that ultimately it is data about them. But if used correctly and used smartly, the benefits massively outweigh the risks, and we have to make sure that we get that balance right. And certainly with training, we have to always make sure that we are at the advanced stages of whatever the next development is, because of course, look, there are parts of the NHS that are still using fax machines. That's why we've got to massively improve that shift to get the best use of the best technology, and Britain, I believe, is a good place to do that because of the unique circumstances of our NHS.
Well, just a little task then for you to tick off as a new minister in the government. So good luck with all of that. Thank you very much. Dr. Suleiman.
Just two things. First, just to Andrew, probably what I'm going to say is not what you would like to hear, but the truth is that the previous government under the Rishi Sunak did something really good that I think the Labour government could continue to build on, and that was the Bletchley Declaration, which is, we're talking about global regulation. There's now a great foundation there. That's a rare, the Bletchley Declaration was a signing by, I think it was about 29, 30 different governments on agreement on AI safety. And this is, of course, this isn't concrete, but it's a starting point, and it could be a great launch pad to continue and take that forward, because it's the main thing that's there at the moment on a global level, at least, that one could build out from to think about healthcare.
Yeah, that summit was pretty much exactly a year ago with that declaration. So to that point, is that something that the new government is going to take forward? We don't want to just focus too much on the UK, but and we want to branch out. And you talked about collaboration, and I want to come back to the WHO because collaboration is key. But very quickly, if you could just respond, please.
I mean, absolutely. Look, we're a new government, but we aren't going to throw everything the previous government did out of the window, and there's no point reinventing the wheel. That work was done, that work is good, and we are going to continue and move it forwards.
So, happy with that response, Dr. Suleiman? Yeah? Good. Okay, thank you very much. Well, audience, we would love your questions as well. It's not just me asking the questions, so please do submit your questions on the app. I will be checking my phone in a couple of minutes to see which questions have come in. In the meantime, as I give you a couple of minutes to submit those, I will continue with this discussion with the panel. But please, don't worry, we will come to your questions very shortly. And so picking up from that very good point that Andrew Gwynn made, which was about collaboration, before he zoomed in to focus on the UK, collaboration is key, not for nations to be working in silos, but to be working together. So, Dr. Kluger from the World Health Organization, how is the WHO facilitating that collaboration between countries to share best practices?
Thank you. So it's a kind of a fourth revolution. So it's not going to be linear, but exponential. And it goes so fast that the only way is really to strengthen our collaboration across regions, across borders, and to do it based on the values of multilateralism, of solidarity and universalism and friendship. And this is very, very important, that we never politicize health to leave no one behind. And WHO is the legitimate body to bring together the 194 countries. If I then trigger down a bit to my region, we have, for example, transatlantic policy dialogues, which we started to create a safe space for health executives, where people can share what are their concerns, also discover opportunities, because WHO as the neutral body to coordinate international health based on the values can create this safe space. We're not economically. The aim is health for all. Another example is the 2-yearly symposium we hold. The last one was held in 2023 in Portugal, in Lisbon, where we bring countries, experts together to share. And from the last one, a number of points came clear. For example, that generative AI should embrace really the principles of open source, collaboration, transparency, to look both at societal and economic benefits, is number one. Number two, even if AI is used to improve healthcare delivery, that we should never forget about the human core, about the emotional intelligence, about the doctor-patients, especially as we face a huge challenge globally with mental health in our youth. 28% of the girls, 14% of the boys from our service tell they feel lonely most of the time or the whole time. And now with the aging population is the same. In our region, for the first time, we have more suicide in elderly people than in younger people. But loneliness is a killer. And then the third one is that artificial intelligence will not fix the structural health system issues we face. So we need sound health policy. It was mentioned to move exactly the policies from disease orientation to a preventative approach throughout the health course. Actually, it's the concept of an economy of well-being.
Thank you very much, Dr. Kluger. And just to really go back to that initial starting point of collaboration and how can the world really work together, there are a couple of questions that have come in from the audience, and you may, whoever posed those questions, may have found that Dr. Kluger addressed certainly part of your questions, but I will put them to him and the rest of the panel now to see if they can flesh out the answers a little bit more. One is currently each country has to develop its own policy regarding the AI usage in the medical field. Who might be responsible to make the policy and regulation on how AI could be used globally? So firstly that, I mean, is it the WHO's responsibility? Is it any single authority's responsibility, or is it purely what we've said, which is collaboration? Would anyone like to expand?
I mean, I can jump into being with, I think it's impossible to have a global regulation on AI. It's just not how law works. And countries are competing on this front, and they've got different philosophical approaches. So the US has got a free market approach when it comes to AI, and they want to encourage development there, so the regulations aren't so stringent. The EU is far more stringent with its recently enacted Artificial Intelligence Act, which a lot of CEOs and developers don't like. And then China has its own approach. So to have a global approach in that regard probably won't work, but I think what's important is to agree on core principles in healthcare that can filter down. And I don't think that's too difficult. In healthcare, we do agree on some certain core principles like informed consent and liability and how we should treat patient data. And so having a process of filtering down those best practices whereby developers are expected to comply with them sort of in a similar way, and I think Feel free to jump in. You want this to be organic?
Just finish your sentence.
No, that was it. I think that's. I'm curious to see I am curious to see the role of the World Health Organization could play in that too, which was going to be my final point.
Yes, and just want to say, Tema, we would like to hear what American, US policies are as well. We've heard various policies from various nations, but yeah. So, would you like to go, please, Dr. Kluger?
Yes. So. The points are all very well taken. Indeed, as a global regulator is probably impossible, but at least the core principles, and we have to be in line with, again, leaving no one behind. And I think it comes back to the multilateral order. They are very important regional bodies. There is the UN, of course, the multilateral, but you have the non-aligned movement, you have the G20, you have the BRICS Plus. So I think it's important to get all those bodies on board, basically for humanity, because we have been seeing with the pandemic that a threat somewhere becomes a big headache everywhere. So that's at least a lesson we should take with us, or the whole world can come to a standstill. So I think, as you mentioned, Professor, the values, the core values are important, and ultimately there has to be a watchdog for at least humanity, and that no one is left behind.
Oh, a watchdog for humanity. Very poignant. Yes. Yes, Professor Ghali, and then yes. Tamar.
Leaving no one behind is a very nice principle, I would say. But speaking about, I myself lived a good deal of my life in the Netherlands, in Europe, but I'm originally Egyptian. Now I'm here for like a decade. So speaking about the differences, there are big differences. And the problem with AI is that it's very easy, in the name of modernization, to modernize serious ethical problems and violations. In the healthcare now, we have the so-called 90-10 gap. So the 90% of the budget goes to 10% of the people getting the diseases and so on. I understand the statistics. We can discuss a lot about the accuracy of these statistics. But there is a gap, there is a divide between the rich and the poor countries. Even within the rich countries, as you mentioned, there are these gaps. The problem with AI, the motor that pulls the AI is the data. Without data, there is no AI. Where is the data coming from? From the advanced countries, from those who are digitally represented. If we speak, we are in an Arab country. Arabic, the language. How much is it represented on internet and in the big data sets compared to English or any other language, not only Arabic? There is equity is not there in the data sets available. If we are going to use AI and push into this direction, and I'm afraid one of the big problems with these hyped technologies like AI is that we will measure the goodness of hospitals by the level of AI included in the hospital, not asking that AI is there to serve a purpose. We say in the Islamic ethics, al-maqasid, the higher objectives, the telos. Why are we using AI? In order to improve the care provided to the patients, not just the AI. So there is a problem with equity. There is a problem with the representative of data. Data will be used, coming from somewhere, will be used on others, although not necessarily they are representative in there. So these are serious issues that we need to take care of.
But whose responsibility should it be then is it Arab Muslim countries in the Gulf region and Arab nations to take responsibility?
Everyone is responsible. So here in the Arab world, if we do not work on the Arabic language and the representation of the Arabic language on the digital world, then we have a problem. And you cannot blame others for not having you. But also WHO, UN, who are representing the whole world, and you see inequities, inequalities, injustices, and you do not take serious measures to get them fixed, also there are problems. So it's not one person or one entity liability only or responsibility.
Thank you. I'd like a quick response, Dr. Kluger, from you, WHO, if possible, to what Professor Khalil's just said, then.
I think Professor Khalid gave the answer indeed, that, I mean, it's everyone's business. Sometimes the problem is, if it's everyone's business, no one is accountable. So that has to be factored in. But speaking to WHO, it's a federated organization. I represent the 53 countries in the European region, but of course there is here, as I mentioned, the Eastern Mediterranean office as well. To give a positive example, because I know that Dr. Teresa Kasayeva is in the room, who is director in WHO globally for TB control, and we worked a lot on AI algorithms to do case finding of tuberculosis, because contrary to what many of you believe, we do have a big issue of multi-drug resistant tuberculosis in our region, and it has been designed and applied in Tajikistan, which is adapted to the language, to the culture specificities as a good model. So I agree that it's ultimately everyone has to contribute.
Thank you very much. And Tamar Schiff, Dr. Tamar Schiff, is the US contributing?
So this is not going to be a very satisfying answer, just to not overstep my own expertise. I think I would defer to Dr. Suleiman about the actual letter of the law, the legislation and policy in the US, if you want to comment on that.
So I actually just want to echo what Professor Ghali said. You hear this a lot in universities and academia. There's often a blame game goes with the West. And when it comes to, representative data sets, and it's true that AI is primarily developed, especially initial stages, from well-funded resource hospitals in places like the US. The NHS took a big leading role for many years, actually. They've been prescribing wearables in certain trusts. But it is absolutely, I think, philosophically, it's the responsibility of other nations to then contribute their data that they need. It's difficult for some when it comes to their resources to be able to do that. I accept that. But there are definitely well-resourced countries around the world who can absolutely generate their own data and come to the table and contribute it. And we can't rely on other countries like the US to say, be more equal or have more equitable data. They may do, but that doesn't answer a much bigger problem, which is we need this data from all around the world, and we need entities all around the world to step up and contribute that. So this is one thing I'd say is great about what's been happening here in Qatar is a lot of the work that Professor Ghali is doing as an Islamic bioethicist, bringing the World Congress in Bioethics in Doha a few months ago underscored that philosophical approach. This report underscores that. So that is stepping up to the plate and contributing, and I think that is the right way of doing it.
Thank you very much.
I'll just quickly, to build on that, I do think there is some, there's not an enforcement body. The WHO is on a global enforcement body. They can set some standards to be adopted by, globally. But I do think there is some responsibility in wealthier countries to invest in infrastructure for countries that cannot invest in themselves, from the lens of saying it benefits all of us globally if the data is more representative. Because exactly as was brought up, there are pockets of vulnerable populations in high-income locations, and those locations would benefit from that reciprocal investment in each other's infrastructure.
Thank you very much. Right, now to another one of the questions from the audience. How can we ensure that the deployment of AI in healthcare is both ethically sound and economically sustainable, particularly when it comes to issues of data privacy, algorithmic bias, and equitable access to AI-driven healthcare solutions? So how can we make sure that AI in healthcare is both ethically sound and economically sustainable? Who'd like to take that? Professor Ghali?
It's very difficult. Ethically sound and economically sustainable is very difficult. Yes, so this brings me to one of the big problems in AI. We spoke about global regulation, and Dr. Barry explained that this is something not within the reach, at least. But we have global principles. Microsoft has principles, the so-called AI principles, Apple, almost every one of the tech giants. But these are, I would say, toothless principles. Principles that everyone would say, yes, I am committed, and these are principles that I initiated, but when you come at the ground, everything would be ethical, everything would be unethical. Why? Because of this gap between the ethics and the economics and finance. The one leading the AI revolution that we are witnessing now are not nations. These are companies, tech giants. And these tech giants, most of the time, are bigger than the companies, are bigger than the countries. And they can even punish countries. China can be an exception, maybe Russia to a certain extent. But for the rest, the main stakeholders and the big players in the AI are tech giants. These tech giants, I disagree with my students. They always say they don't have ethics. I say they have. They have an ethical framework. Maximize the profit, minimize the loss. That's what they care about. So if anything goes against this ethical framework, we will have a problem. So ethically sound, economically sustainable, these things will be problematic. But I would say it's not a hopeless case. These companies, they care about one main thing, about the customers and the people. And the main thing through which we can convince the customers and raise awareness is ethics. If they know that people wouldn't like this product, if the employers in the company make a problem about misusing some of their innovations and discoveries and so on, and they know that this will not serve their main purpose of maximizing profit and minimizing loss, they will not do it. So this is how things can be. And here I am biased because I'm an ethicist myself. So I am promoting ethics as a solution to the situation. But this is what I think. We shouldn't stop speaking about ethics, about raising awareness, because this is how we can make this difficult combination between making things ethical, but also will not cause losses for the companies that are responsible for this, and they think this is the most important thing.
Thank you. Andrew Gwynn, did you want to come in?
Yeah, so assume we have a framework that is agreed on the use of the technology and on the data and the ethics surrounding that. What's unethical are the health inequalities that are stark, even in a country like the United Kingdom. On my first day as the public health minister, I had a briefing, and they showed me a simple bar chart with 2 bars on it. One was the life expectancy of a female living in a wealthier part of England, and the other one was a female living in a more deprived part of England. On average, that woman in the wealthier part of the country will live to around 80. The other woman will live till 70. So 10 years shaved off her life expectancy. But worse than that, part of those 2 bars were shaded in a different colour. And that's the healthy life expectancy. That woman that will live on average to around 80, she falls ill at 75, way into retirement age and around 5 years before she dies. The other woman falls ill at 52. That's 16 years of her adult working age living in pain, often economically inactive and probably in poverty as a consequence.
A stark example, but your point is?
And these are preventable diseases, and the clue is in the name, they are preventable. And using AI tools smartly as a public health and prevention aid, we can identify those that are susceptible to a whole set of preventable illnesses, and we can make smart interventions as a consequence of that, and thereby narrow those health inequalities and hopefully extend healthy life expectancy for some of the poorest in our country. And that's why it's both ethically correct and it's economically common sense, because it cannot be economically sensible to keep working age adults in poverty and ill health.
Thank you very much. Thank you to those points, and hopefully that has answered your question, whoever posed the question about ethically sound and economically sustainable. Thank you very much. Another question here from the audience. Can the burden of proof to avoid negative consequences not be placed at the responsibility of producers of AI innovations and within approval processes too? Hope that makes sense to you. Barry, does that make sense?
Yeah, a little bit, but perhaps Professor Ghali.
Yeah, as I mentioned briefly in the beginning, putting AI in the scene of healthcare would involve new stakeholders, the people who made this smart machine. Usually, I manufacture a tool for the field of medicine. Once I finish the manufacturing, you gave the license, my rule is done. Because if there are any mistakes, it's because of the non-expertise, negligence of the physician, people who are using the machine. But now, this machine continue working. So these people who made it should be there on the table. Not necessarily that they are by default reliable whenever we have a mistake, but they can be. I give an example. If we have an AI program, and I think that there were some, but I'm not sure. So, but for the sake of argument, imagine we have an AI program for a treatment plan for a disease. And then we tested it, we tried, everything goes well. And then we started using it in Nigeria or in Mozambique, and we tried, and it doesn't go well. And patients are not improving, maybe getting worse, maybe some people died. And when we examined and tried to know what the problem is, it's the training data. The training data was coming from white people, let's say in Europe, in the United States. Their genetic structure is not the same like those, the black Africans. So there was bias in the data set. So where did the problem come from? From the data scientists, people who choose the data. They should have known that there should be this, and those who collaborated with them from the medical team and so on. So you cannot pinpoint and say the problem is the physician. Not anymore, because we are not in the conventional situation now. The physician is using a machine that has been tested, doing well, etc. But now it's because of the type of data that we used. So it's not anymore the physician by default. But it is also not the AI developers by default. It is a collective thing. It's a group work. And I am afraid that this will end up, we will have a killed person, but we don't have a killer. There is nobody who killed. So the blood will be divided between so many to the extent that there is no criminal at the end. But there should be, this is the work of the lawyers, who should measure the percentage of everyone involved so that we can have good regulations at hand.
So collective responsibility. Would you like to come in just briefly? Because I want to get to a couple more questions.
So burden of proof is to talk about the legal standard of proof. I'm guessing where the question is coming from. Just to be brief, in medical liability and AI, there are three potential responsible parties. That's the doctor, the hospital or the healthcare institution, and the developer. And I think the question was premised on the developer. Now, just to cut a long story short, as it comes to legal analyses, we're finding that developer liability is just going to be very unlikely in this area. The most likely areas are responsibility for the doctor, when their malpractice insurer will pay out, and or the hospital. The hospital being, or the healthcare institution, also being responsible. Now, that splits apart depending on which country you're in. In some countries, doctors are employees of hospitals, meaning hospitals are automatically liable when the doctor messes up, basically, and causes harm. In other countries, doctors are agents and they're not directly employees. So the emerging thought is that we should be moving towards perhaps something called enterprise liability, which kind of touches a little bit on what Professor Ghali was saying, which is that the hospital and the doctor will be collectively responsible, and particularly because nowadays a lot of the developers are hospitals. A lot of hospitals are the ones who are deciding to either buy in systems, so they have oversight over them, or they're making them in-house. So that's the likely path for the law as it's developing.
So enterprise liability, interesting. Yes?
Just a very quick comment. I think this is less to who's to blame, who goes to jail, who pays the fine, but I do think that all this calls into focus that we really need a paradigm shift. Previously, it was someone develops the device is developed, period. It goes out to the clinical setting, and then someone uses or misuses or et cetera. I think now we can't think about it that way anymore. The process has to employ iterative repair and improvement, and so there's not that same sort of, the developer was responsible until this point and the clinician was responsible until this point. I think we're working with a completely different framework.
Yeah, and as we heard there, enterprise liabilities, so yeah, very different. Thank you, but thank you for your answers on that, because it's obviously of great interest to the audience. We've had a couple of questions about accountability, so hopefully that has answered your questions, audience. An interesting one here from one of you: what are the fears of AI in health being weaponized, arguably already happening in biological warfare? Who would like to tackle that one? Any of you looked into that at all? AI in health being weaponized? Andrew Gwynn.
So there's always a risk in whatever you do in health, and I've learnt this very quickly, that it can be used both as a political football, but also the conspiracy theorists come out of the woodwork. And you see that over a whole range of healthcare issues. Take, for example, the pandemic accord, which is going to be a really important piece of multilateral work across global health. There are critics in the United Kingdom that have come up with all kinds of conspiracy theories behind it. The same is true with AI and technological advances. There are legitimate concerns over data, over the lack of human oversight on certain procedures into the future, and where this may inevitably lead if you don't have the right regulatory framework in place. But look, the challenge to us as healthcare leaders, and particularly for ministers and politicians, is to get that regulatory framework in place, is to get trust in the population behind the benefits of AI. Because if we get it right, as we've all acknowledged, then the benefits far outweigh the perceived risks. But what we can't afford to do is to let those that will make mischief, that will want to cause trouble, and that will want to take us back to the Stone Age, win. We can't afford to let that happen.
Andrew Gwynn, thank you very much indeed. Well, 75 minutes goes rather fast when you're having a very interesting discussion, and such a profound discussion on ethics in AI and specifically healthcare. So as we are coming towards the end, and thank you so much to you, the audience, for your questions. We got through a few, but unfortunately not all of them, but thank you so much for posing them on the app. Just to wrap up, you know, these are serious issues that you are, as the experts, really grappling with. So I don't want to undermine the seriousness of the issues, but recently the Royal Institute of Philosophy in London held a panel discussion themselves entitled, "Is Ethical AI a Fantasy?" So I would just like to conclude on a maybe slightly lighter tone, but still, you know, giving the context of what we're talking about, AI in healthcare and the ethics. What do you think? You can give a yes or no answer, or a maximum 30 seconds, because we don't want to run over. So, Andrew Gwynn, starting with you, is ethical AI a fantasy?
Only if we let it be.
Thank you, Andrew.
No, not at all. That's why we build processes and laws and regulations to ensure the ethical use of such devices. So, no, absolutely not.
I'll also go with no, just because if we're deliberate, then it doesn't have to be a fantasy.
There is an old Dutch saying which says, "Trust arrives on a turtle and leaves on a horse." So I think we really have to create trust by walking the talk.
Okay.
Surely not. No, it's possible. Ethical AI is possible. The question is how difficult it is.
Thank you very much indeed. Some interesting answers to conclude. Thank you very much to my panel, Professor Mohammed Ghali, Dr. Tamar Schiff, Dr. Hans Kluger, Dr. Barry Suleiman, and Andrew Gwynn from the UK. And thank you to you, our audience.